Today we are going to talk about restoration of endodontically treated teeth. This is an article published in Dental Update in January 2025. This is a greatly researched and greatly debated topic. Here the key takeaway concept is that the proper loss of proprioception and loss of moisture is not responsible for failure of the restoration of endodontically treated teeth. Rather, they are saying that pericervical dentin, that is the cervical dentin around the cervical margin, 4 mm above and 4 millimeter below, is the most important structure or the tissue of the tooth that needs to be conserved. The correlations, as I have mentioned here, are pathways of pulp, restoration of endodontic treated teeth chapter. Another algorithm I find quite interesting is in British Dental Journal, 2021 September issues. The ferrule is the amount of tissue that is encircling the tooth on which the direct or indirect restoration is placed. It should be 2 mm, greater than 2 mm, and ideally more than 1 mm in thickness. Other concepts are immediate dentine sealing, in which you used a filled resin to seal the dentine of the excess cavity, and deep margin elevation, when the margin of your preparation is below subgingiva or below gingiva. You are going to elevate it by isolating it and using a bonded restoration to bring the margin of your preparation above the gingival level. You might need some gingival surgery or cavitate or something like that to eliminate the excess growth of gingival tissues. Moving on. First, they have said that we are going to evaluate the tooth. Evaluate the tooth is divided into three categories. The first category is low risk, in which the tooth should ideally be vital, or if it is non-vital, it is a single-rooted non-vital teeth with or without periapical lesion. When we move to the medium risk, it is a multi-rooted tooth which is either vital, non-vital with a periapical lesion or without a periapical lesion. However, when you are going to high risk, this is a tooth which has failed in an endodontic treatment and you are going to do re-endo on it. Then they said CRW or coronal residual wall remaining or something like that. They said there are 4 walls or 3 walls with ideal height and width of the ferrule. In medium risk, the height is up to 2 mm, but there are 2 walls or 1 wall. In the high risk, you have to generate the ferrule. In the restoration of the marginal seal of the preparation, they said all the margins of your excess cavity preparation or after you have completed your root canal treatment, all the margins are above gingiva. In the medium risk, all the margins are at the gingival level or below gingival level, but which can be used with the margin elevation technique. All the margins are below gingival level and you have to do complex gingivectomy or something like that. Then we go to the periodontal requirements or criteria of that tools we are going to use for endodontical for the restoration. The periodontium should ideally be normal. There is no recession, mobility, or pocket depth is shallow in low risk. But the pocket depth should be either moderate or there is some gingival recession in medium risk. When we go to high risk, there is a furcation involvement, gingival recession, or mobility of some kind that you need to do with surgical periodontal therapy. The position of tooth is very important, as tooth should be either anterior or if it is a posterior tooth, it is in a untreated quadrant. There are minimal restorations or any other kind of dental treatments there. In the medium risk, the tooth is going to be a part of a short span indirect restoration, such as removable cobalt chromium bench or a bridge or anything of that kind. In a high risk tooth, the position of the tooth is in a heavily restored quadrant, or it is going to be a part of a long span restoration, going to put considerable pressure. And occlusion is favorable in low risk. Occlusion is also favorable, might be slightly unfavorable in medium risk, but it is unfavorable in high risk. In dental wear, there's a minimal dental wear in low risk. but there is high static demand causing it to be placed in medium risk but moderate dental wear. In high risk tooth, there is so much dental wear that it is being compromised in function. Then we are going to look at the then we are going to do post and core build up. They have the different criteria. The table was really complex, so I divided into different places. For 4 walled or 3 walled ferrule tooth that has greater than 2 mm height and greater than 1 mm width, we are going to put them. But when height is up to 2 mm, not more than that, and width is adequate, we are going to do indirect composite or indirect any kind of overlay only restoration. But when the ferrule height is greatly reduced, I think less than 2 mm and width is also compromised, we are going to use endocrine to take part the bond to use the bonding capability of the pulse endodentin. When we need to do a core buildup, we are going to use is when are we going to do the core buildup? That is when the 3 wall defect, not the 4 walls, but one of the margin is subgingival. We are going to do immediate dentin sealing and the margin elevation. After that, the restoration criteria is same as for the left side of the notomen as in one. The post is required when the defect or the excess cavity is only 1 walled. We are going to do partial crown, and under that partial crown, the restoration criteria is the same as for the first part. That if we are able to make 4 walls, ferrule is restored, then we are going to use endoground or indirect composite restoration or the restoration. And if there are no walls and the tooth is at the level or bone level, we are going to extrude the tooth orthodontically, then we are going to restore it as per the guidelines. After all this is done, they have stipulated the restoration recommendations here. For anterior teeth, we are going to use direct composite when all the marginal ridges of the tooth are present. Indirect composite is one of the marginal ridges such as mesial or distal side is lost. And if both of the marginal ridges are lost, we are going to use the reinforced composite with ultra high molecular weight polyethylene fibers. In the premolars and molars, if one of the marginal ridges is lost, we are going to cover the cusps if the thickness of cusp is less than 2 mm. But if both the marginal ridges is lost, we are going to cover the cusp with either full or partial coverage restoration. For cervical margin relocation, you are going to look at older dental update articles in which it is elaborated in detail. I think in 2021 or 2022. Thank you for watching. Do comment and subscribe. We label more.